Any questions on anything before I get going? Maybe from the tests, anything? I cleared out the sticky board, so you guys should have plenty of room now to write all your questions. On pediatrics, right? We're going to continue on with that nice continuity of education from your first block today, right? Fantastic. So, just to recap, this is some of this is going to be a little bit familiar, but how many of you have like a perfect recall of every lecture we had in pharmacodynamics? No one? Okay, perfect, great. So this will be a nice bit of review for you guys. Talking a little bit about some of the kinetics and pharmacodynamic differences in children. Good as a review, and then we'll get into specific disease states. I'm not going to cover absolutely everything that's out there, but I'll talk about some unique cases for using drugs in children. We'll talk about some cases where we're using new drugs that we may not have used before, or some old drugs in some new circumstances. For instance, like using caffeine in neonates. And we know why we use that? Because they're too sleepy. Said, baby, you don't need to sleep 16 hours a day. No, it's for apnea, right? So look at some cases where we can actually use drugs for some new purposes here. So anyway, and again, we know they're very heterogeneous as far as populations go. We know that a 3-day-old is going to be acting very different from a drug standpoint than, say, a 3-year-old. And again, you can't just treat them like little adults, unfortunately, make things a lot easier, but that's certainly not going to be the case here. And so they're constantly undergoing physiologic changes. We'll cover some of the big parts about that. Again, this is a bit of a review, so we may go fast through this kind of initial section. Anyway, again, keep in mind when you're looking at drug dosing, especially when you're dealing with NICU children, you're going to find that you need to keep in mind things like gestational age and postnatal age. Because if you go and you look in LexiComp, you're looking at the Peds Lexi, you're going to find there's very specific recommendations for neonatal dosing. Because again, they're such a different population that you need to make sure you're looking at specific dosing recommendations for them. And so in some cases based off their gestational age, sometimes it's based off their postnatal age, sometimes it's based off of their weight in addition to their gestational age. You know, there's lots of different combinations that are out there. But it's important to take all of those into account, because if you have a kid born at a much earlier gestational age, you know, what does that mean as far as their organ function? So you have a kid who's, say, born at 38 weeks versus a kid who's born, say, at 24 weeks. How do you think that kid at the 24 weeks gestational age is going to be kind of functioning from an organ standpoint versus the 38-weeker? Not great is the answer, right? Because again, they're very immature. They needed more time to cook, but here they are in the world. So we need they still need time to mature. Their organs are just not going to be functioning as well. So again, we talk about gestational age being the time since the last menstrual period. Again, you can do this based off of history. You can do this based off of actually measuring the fetus in utero, things like that. And again, what's a full-term infant? 37, 38 weeks or so, and then anything before that obviously would be preterm. What's like the earliest time frame that you can consider a fetus viable usually? It's like 24 weeks or so, but much earlier than that can be pretty difficult. And again, those kids can be very difficult to manage because again, they're just not ready to come out yet. But you know, here they are, and we'll talk about some different ways you can manage them. Anyway, typically postnatal age is once they're born, how old they are. So if you see a 2-day-old, 3-week-old, whatever, 33-year-old, like that's all basically the postnatal age. And then post-conception will be just the two put together there. And again, preterm is anything less than 37 weeks. Full term we consider 37 to 42 or so. And then as far as the lingo goes, when you're talking about neonate specifically, what time frame are we talking? The first 28 days of life, right? So technically, once you're past that 28 days, once you're past that first month, you're no longer a neonate. Does that mean that once we have a kid who, say, is 29 days old, we kick them out of the NICU? No, we keep them around. We don't just kick them out just because they're age restriction. We actually can keep them around for weeks, months, depending on you know, how they are developing. Because again, a 24-weeker who is 8 weeks old is just now starting to get to a point where they should have been born in the first place, right? So you have to think about these sort of things from that regard. But as far as the terminology goes, the neonate is really just that first 28 days or so. Infant is going to be considered to be that first year of life. And you may hear some people talk about infants as when they're really referring to a NICU baby. It doesn't really matter so much from that standpoint. Just know that first year of life is going to be the infant. Once they get above that, what do they turn into? Toddlers, yeah, absolutely. Even if they're not technically toddling, when they're in that 12 to 24-month age range, they're considered a toddler. Just like my little girl Phoebe is now technically a toddler, even though she's like crawling like a demon. She's getting up into everything. She's not quite toddling yet, but she's getting pretty close there. And when that happens, things are going to get real bad around the household. So make sure you put child locks on everything. Make sure you have appropriate child gates, because otherwise those kids get into everything. and they will, despite that. Are there any child-proof locks and things that are out there? No, nothing's child-proof. Everything is child-resistant, but certainly not child-proof. And in fact, you know, we talk about like pill containers, they say like they're child-resistant. I've seen older people have a harder time getting into them than toddlers do. So again, just know nothing is child-proof. But, and again, adolescents, when you get to like 13, 17-year-old, you have younger children, but at that point, the lines start to get a little bit more blurry as far as physiologic function. As they get closer to adulthood, they're going to be functioning much more like adults, and you're going to find that typically when they're in adolescent stage, we're going to be treating them essentially, from a physiologic standpoint, pretty close to how adults would be treated at that point. And again, we're going to go through the different organ systems here and see how function is going to change depending on the maturity and how old the patients are going to be, and look at how that impacts how drug dosing is going to be occurring, right? So looking both at how we need to change maybe the dosage form that we're using, changing how frequently we have to give a drug, how big of a dose or small of a dose we need to give, etc. So looking at absorption, right, we're going to go through the 4 components of kinetics here: absorption, distribution, metabolism, and excretion here. Looking at absorption, do you think, let's talk about the NICU kiddos, do you think they're going to have better absorption, less absorption of drugs? What do you think? For the most part, you're going to find pretty good absorption for a lot of things, especially when you think about the different routes. If you had to think about things like the transdermal route, how do you think, how developed do you think a NICU kid's skin is versus, say, an adult? Not nearly as developed. You're going to find it's much thinner. It's going to be much more easily able to pass drugs from one side to another. So because of that, you have to think about things like drug absorption. I'll give you some examples, things we've probably talked about before. But remember that things that will affect how well drugs get absorbed are going to include, one, the molecular size of the product. So the smaller the molecule size, easier it's going to be absorbed. Particle size, the smaller, again, is going to be a thing to consider there. And then getting into pH and pKa. You guys remember when we talked about that last? The Henderson-Hasselbalch equation. Anyone? No? I don't see any pain to look, so you probably have repressed that memory, but it's going to come back again. And remember, that tells us how much of a product is in the ionized form, essentially. And we talked about when you're crossing a biologic membrane, you want it to be ionized or unionized for it to cross. You want to be unionized, right? You don't want any charges on there, because a positive charge is going to make it just bounce right off that membrane, okay? Because again, as it gets more charged, it becomes more hydro or lipophilic. The more charge you have on it, the more hydrophilic it is, right? It's become more polar. If you take that charge off of it, you're going to make it more lipophilic and cross much more easily. And again, we're going to look at the different sites for absorption and see how those change a little bit. So looking at gastric absorption, things you have to consider. So when a kid's first born, how do you think their gastric pH compares, say, to an adult? Higher or lower? Probably going to be higher, right? So what are some factors that go into that? So specifically, the first couple of days of birth, pH is going to be much higher, because again, what do you think has been in the GI tract for the most part up until that birth? Well, there's amniotic fluid, right? Because the kid's just going to passively have some ingestion of amniotic fluid. And what you actually end up finding is that it has a neutral pH for the most part, and so that's going to neutralize any potential acids they have there. But also, their gastric acid production is going to be pretty low, and the more premature they are, the less likely they are to be producing a lot of those acids. And so because of that, you typically are going to see pH is going to be increased relative to what it would be, say, in a few weeks or a few months after at birth there. And again, it's going to be affecting how well drugs get absorbed, whether they are weak bases or weak acids. We'll look at that again in detail. And then also things like gastric emptying time are going to be much different between, say, an infant versus an adult patient. And gastric emptying time is just what? Is how fast we're shooting stuff through, right? And so looking at the GI tract for an infant, is it pretty quick or pretty slow? It's pretty quick. If you actually look at the number of bowel movements they're having per day, it is very much more so than you see for like an adult patient. So again, gastric emptying time tends to be pretty quick for these infants here. And again, I'm mainly focusing on infants because they are the most physiologically different than the normal adult patients we're used to dealing with. So that's kind of what I'm referencing mostly. So looking at pH-dependent passive diffusion, as I mentioned, especially for preterm kids, the pH is going to be elevated there. And then as gestational age goes up, you're going to find their acid production is going to be more readily available. They're going to be producing more acids there. pH should start to go down. As I mentioned, that first couple of days is going to be relatively neutral, mainly due to that amniotic fluid there. And then it's going to start to kind of really peak up, because again, they want to get that pH down. And then by the time they're about a month out, it should be relatively low at that point. So it should kind of stabilize things out there. And then by 3 months or so, it should be pretty close to adult levels. Now, what does that mean for drug absorption? That means when the pH is elevated, what gets absorbed more easily? Remembering that like dissolves like. So weak bases, right? So if the pH is closer to 7 or 8, things that are more like weak base drugs are going to be able to be more in the unionized state, and they're going to be absorbed more easily. Versus acidic drugs, they're going to be more in the ionized state when the pH is high. That's going to make it less likely for those drugs to be absorbed. Okay. So weak acids. Anyone know an example of a weak acid? I'll say LSD. It's a pretty strong acid. Just kidding. Aspirin is a very good example, right? So something like aspirin, that's something you typically think about giving to a lot of little kids, but we do it occasionally, especially with like congenital heart defect kids. We will have less absorption of something like aspirin because it's going to be in the basic medium. It's going to be in a much more ionized state. It's just going to bounce off those membranes there. It's going to be much more difficult for it to be absorbed. Look at things like gastrointestinal emptying time. You're going to find this also can affect rates of absorption. So if you have a very fast emptying time, things are passing through very quickly, what do you think it does to absorption of drugs? Should decrease absorption because you have less contact time with the GI tract, right? So having a lot of bowel movements, things are moving across very quickly. This may affect the absorption of certain drugs. So for instance, if they had things like, an extended release product, for instance, you may not have as much contact time, may not have as good of absorption there. So that can be playing a role. And typically you can find that many things can affect emptying time, especially if you have things like impaired blood flow, maybe due to a congenital heart defect. You may have less blood flow going to the GI tract. Less blood flow means less activity. That can be playing a role here. Type of feeding can be important, whether they're breastfed or formula fed, anything like that. And also, their actual gestational age plays a big role here as well. And so typically you're going to find this is going to be slower. Infants that are less than 6 months of age, and then typically get a little bit faster there as time goes on. And again, shorter transit time means less absorptive contact time. Drugs are not going to have as good a levels there. And it may explain why you have some variability in levels between giving, say, one dose of a drug to a kid who's only 1 month old versus one that's saying maybe is 3 months old. Now looking at some other absorption, so not just the oral dosage form, but what are some other routes we can give medications to, say, like a NICU kid? Yeah, we can do topical products. What else? Rectal is actually a very good way to give as medications because, again, you usually can't put up too big of a fight there, right? And again, what's nice about the rectum as far as absorption goes? Very vascular, very thin membranes. You can absorb drugs very easily there, right? So anyone know like a common rectal medication that we give? Just for little kids? Tylenol is really good one. Acetaminophen is great as an antipyretic, analgesic. We give it very frequently there. We can do some suppositories as well for things like, mineral oil or glycerin or things like that. But yeah, acetaminophen is one I always think about as being most common. But anyway, so some other ways we can look at it. So we can look at the intramuscular route, right? We can look at the IV route, etc. And so what you're going to find is when you're looking at changes between, say, a neonate versus an infant, so again, that first year of life versus the first month, and then children, what you're going to find is that typically for muscular blood flow, see is relatively reduced versus kind of increased with infants, and then with children it becomes much more close to the adult pattern. So what do you think this does for absorption in the neonate? So if I were to give an intramuscular dose of a drug to a neonate and they have reduced blood flow, what does that do to the absorption? Decreases it, right? Because you need the blood to get to the muscle in order to absorb that drug, and then you can send it out to the rest of the circulatory system. If you have decreased blood flow, you're going to find you have less absorption. It may not be a great route. Versus with infants, they start to become more active, more mobile, they're moving around, more blood flow happens, and that may actually increase the absorption there. So you may find in certain cases, a certain route may not be appropriate based on things like the muscular blood flow, right? Looking at mucosal permeability, we mentioned very, very efficient for neonates because their membranes are so thin, and skin permeability as well is very, very thin, so it's going to allow for very good absorption there. Anyone remember the story I talked about where the neonates were shown positive for THC? Remember that? So here's an example of the transdermal absorption that can occur with an infant. So there was a hospital where these women were giving birth, these neonates, and one of the things they were doing where if the mother was at high risk, they were worried about drug use in the moms, they were testing the babies, giving them a urine drug screen. Because presumably whatever mom was exposed to, that fetus was also exposed to as well, right? And so they're testing these babies, the urine drug screen, and showed positive for THC. And you're like, oh, what's going on here? The mom must have been doing drugs during his pregnancy. It's called DCF, Department of Children and Families. And they go back to the mom, and mom's like, I've never smoked pot a day in my life. And so what do they do at that point, do you think? Drug test the mom, right? So presumably if the baby's positive, mom should be positive as well, especially for something like THC sticks around for a good long time, especially for chronic users, or users of the chronic, I should say. Chronically using chronic will lead to levels that stick around for a while. Anyway, so they tested the mom. Sure enough, moms were negative. So they're like, what the heck is going on here? Mom's negative, baby's positive. What's happening here? And they actually were able to trace it back to a lotion they were using in that unit there. And when they actually found it, I think it was like an Aveeno product or something like that, but they had absorption of one of these compounds that actually looked structurally enough like THC that it tripped the assay. And so once they were able to link it back to that, said, oh, this is what was happening. These babies were able to absorb this relatively easily because they had that thin membrane, and they had this product in their system that was showing positive. So of course they stopped using that, and then they were no longer positive for THC. Again, just goes to show you they have a very underdeveloped stratum corneum. They absorb things very well, and that can lead to big issues, right? So, for instance, I had one case where this dad was on a kind of a custom-made cream from pharmacy for chronic low back pain. It had all kinds of products, and it had ketamine, it had amitriptyline, which is what kind of drug? TCA, had local anesthetics, and had all kinds of stuff in it, right? And so he was using this for chronic low back pain, and then they had a newborn in the house. The mom was giving the baby a bath. Bath water is usually pretty warm, increases blood flow to the skin, and then the kid had really bad diaper rash, right? Nice inflamed diaper rash skin, had a lot of good blood flow, and then so the mom accidentally grabbed the wrong cream, meant to get the Desitin or something like that. Accidentally grabbed this custom-made pain cream, and then rubbed it on all these nice skin folds and everything. Whereas again, thin skin, occluded skin, and then put a diaper over it. And usually, occlusion does what to drug absorption? Increases it, right? So all of a sudden they put the baby down. That man, this baby's sleeping great. Well, they go back in a little bit later, can't rouse the baby, call 911, get the kid in, gets intubated, ultimately does fine. But they were testing blood levels of the kid. Once they figure out the history, they actually checked the blood levels, and they were able to find metabolites of a lot of the drugs that are in that product, including things like ketamine. So again, you gotta be really careful with this stuff because kids can absorb it and have pretty dramatic effects as compared to an adult who has a nice kind of more thick sort of stratum corneum, better developed there. So there's something to keep in mind, right? Anyway, so as I mentioned with intramuscular absorption, it depends on having good blood flow to the area to make sure that they can actually absorb the medication from the site. And again, we're also going to find that the volume distribution is going to be playing a big role here as well. Anyone remember kind of my analogy for how I describe the volume distribution for like a baby? Like a big bag of, it's like a big bag of water essentially, right? So you're going to find that they're very high water content, not a ton of fat initially, and so that's going to be affecting the volume distribution, and that can also affect intramuscular absorption as well, as we're going to see there. And again, depending on what's going on with the kid, depending on how premature they were, this could affect that blood flow to the muscle, depending on the percent of water in the muscle itself, which can increase that apparent volume. Looking at things like muscular contraction, etc. All of that can lead to impaired absorption. So intramuscular may not be the best route for some of these kids there, right? And again, you may think, well, why would I ever need an intramuscular route for a neonate? Why can't I just give it IV? What's the problem starting an IV on a neonate? They don't just come born with adult-sized veins; they come with neonate-sized veins, and so sometimes getting access can be very difficult, as the case may be. We'll look at some alternatives to that in just a minute. As I mentioned, rectal absorption, great bioavailability for a lot of that stuff. So again, if you have medications that maybe the oral route's not a good option, rectal can be very good. Again, it's hard for a kid to spit out. You can spit out oral medications at you all day, but rectal medications are going to be a little bit more. You can kind of ensure better compliance for some kids there. However, keep in mind that if they're having a lot of rectal contractions, things like that, they can spit the suppository back out at you. So sometimes you have to kind of keep their cheeks shut for a while, just to make sure you give it time for the enema. It sounds silly, but you have to make sure that the suppository or the medicine actually has time to melt and absorb. Otherwise, you have to redose the kid, and it could be kind of uncomfortable for them. Another way, if you didn't have IV access, something can be very useful. Because imagine you guys having a hard time starting an IV on a kid in the hospital. Imagine if you were, say, in an EMS rig, in the back of an ambulance, trying to start an IV on an infant. That can be really, really tough. So you need an alternative. If you need to get medication and get it quickly, this is where things like intraosseous absorption can be very useful here. Because again, by going into the bone, you basically have a nice non-compressible vein that you can administer fluid into, you can administer drugs, anything you want, because it will get into the systemic absorption very, very quickly. It's almost like having another IV. And so basically you have this little power drill set. You can have some, there's also manual ones you can use as well. Here's an example of a manual one. But it's very convenient, relatively painless for the most part, depending on where you're actually starting the actual injection. But again, the bone's not full of nerves, so you don't really feel that quite so much. It really doesn't, from what it's been described to me, does not hurt that much worse than an IV actually would. Again, that sounds like that's not true, right? But if you want to do some experiments, I'm sure we could do that. Maybe like CPSS next in the summer or something like that. We can do some experiments. But again, very, very useful for emergent settings, and oftentimes if you see kids coming in from like EMS in the emergency department, they probably have an IO already placed, especially if they're really, really little there. Again, I have had some situations where, and again, these things look like big thumbtacks, essentially, and the size will depend on the size of the patient. We had one patient who came in with cardiac arrest, as an adult patient, had a cardiac arrest, had one of these IOs placed, and unfortunately the patient died, so they wanted to get the patient ready for their family to come see them, and we were trying to get the IO out, and whoever was pulling it accidentally pulled off the thumbtack portion of it and just let this big kind of needle sticking out, and we're just like, how do we get this thing out, because there's no really good handle on it, so we ended up having to get some pliers, and medicine's not often dignified, but just something to consider there. Sometimes you have equipment malfunctions, but very good for getting medications into the patient when you need it pretty fast. Anyway, looking at percutaneous absorption, we mentioned that their stratum corneum is underdeveloped. They're going to absorb things very well. The other thing you have to consider as well is that their BSA is typically a lot larger compared to their size than you would see for an adult patient. So that means even covering a small area of their skin is quite a lot of area for that patient there, and that helps to increase that absorption as well. Because you remember, the things that help to increase drug absorption was, one, the concentration difference, but also this area that you're actually applying the drug to. So the larger the area, larger that percentage of their BSA, their body surface area, the more drug they're going to absorb, essentially. Okay. You can be really careful here. For instance, another case where you can have a lot of problems if you were to apply, say, antihistamine lotions to a kid's skin, say an infant or a neonate, they can have anticholinergic toxicity, right, from that Benadryl getting absorbed transdermally, right? They've seen cases where they were trying to give a kid an isopropanol bath. Isopropanol is another name for what? Rubbing alcohol, right? It's isopropyl alcohol. They actually found hypoglycemia lethargy. Basically, the kids were absorbing it and essentially getting drunk. Isopropyl has the same effects as ethanol, but it can cause hypoglycemia in kids, and it's a big issue there. So again, sometimes the ways you can actually cleanse the babies, what you can use, can play a big role here. Using things like iodine-based scrubs and things like that can also cause things like hypothyroidism potentially for these kids. So little things to consider. Looking at the distribution for these kids, as I mentioned, they typically have a lot higher percentage of body water, so you're going to find that the volume distribution for hydrophilic meds is going to go what? It's going to increase because they have a lot more space and the apparent volume for that drug to partition into. So volume distribution is going to be much higher for hydrophilic medications. Okay, and if you remember, how do we actually figure out what volume distribution is? Well, basically, it's the dose that we're administering to the patient divided by that concentration at time 0. Right? So again, the bigger the number, the bigger the volume distribution, the larger the area that these drugs are partitioning out into, which means that for a given dose, that C0 is probably going down. And that makes sense because where are we measuring the concentration of the drug from? From the blood, right? We're measuring a blood concentration as a surrogate for what's actually in the tissue. And so in these cases, if that level drops down, it means that the drug is going somewhere. Well, it must be out in the tissues there, and that's why the volume distribution gets larger. Again, this just gives us an idea of just where the drug is going to in the patient, and that can dictate how well it's going to be working potentially. And this is also playing a role if we have drugs we're actually monitoring levels for, right? If you're doing therapeutic drug monitoring, you have to make sure you're taking this into account based off their volume distribution. So getting into this, again, you kind of refer back to this picture here. Again, I wouldn't focus on this guy so much because he's quite haunting. But focus on the graphs, because this tells you quite a bit about the different pharmacokinetic changes that occurs over time. And so this one's good about talking about the development of distribution in these kids. But things that can affect the volume distribution include things like lipid solubility, looking at plasma protein binding. What does plasma protein binding normally do to volume distribution? If it goes up, volume distribution goes, well, it should go down, because you're actually finding that more of that drug is being held up in the blood, and if it's there, it can't actually go out into the tissues. So volume distribution goes down in those cases. Tissue binding, if that were to go up, what would happen to the volume distribution? It would go up, right? Because more of that drug is being siphoned off of the blood and is being held in the actual tissues there, right? All this stuff comes back at some point, right? But you keep in mind that a lot of different disease states can also affect the volume distribution. So, for instance, if you have a lot of edema, maybe due to CHF, if you have burn victims, all these different things can affect the volume distribution pretty greatly and can affect how that patient is going to respond to a given dose of a medication. So looking at the newborn infant, typically 70 to 75% body water is making up their weight there. And also they have a higher extracellular water content as compared to adults there. They have less fat tissue, less muscle tissue, so I kind of talk about them as kind of big bags of water. And because of that, their volume distribution for hydrophilic meds is going to be much higher. And I'll show you some examples of how that actually affects the dose we have to administer to get the same level, essentially. Okay. And again, just think about the kids having a much bigger bucket for hydrophilic meds, right? That drug, instead of staying in the actual bloodstream is going to be partitioning out into the tissue there. They have much more water for that drug to partition out into. Okay, so basically what that means is that for certain drugs, I have to give a bigger milligram per kilogram dose than I do for an adult patient in order to get the same blood level. Okay, I'll give you a clinical example of this in a second here, but this mainly applies to hydrophilic medications. So as an example, gentamicin, which is what kind of antibiotic? Glycoside, what do we use it for? Broadly, gram negative infections, right? What does it cover? What's the big bug that it covers? Pseudomonas, right? Pseudomonas, right? Very important stuff to know about gentamicin, right? It covers gram-negative infections. You might even see it pop up potentially on a homework assignment you guys might have. Interesting. Anyway, gentamicin is a very water-soluble medication, right? It undergoes almost entirely renal elimination. These are things you want to know about gentamicin. We also have to do drug monitoring for this one because levels get too high. Anyone remember what kind of toxicity you can see from it? Ototoxicity and nephrotoxicity, right? Those are the two big things you think about. So you want to make sure you keep the levels in check there. So to give you an example of how volume distribution is going to affect the dose we're administering here, we see that neonates are going to have, again, a higher volume distribution because they have much more water for that gentamicin to partition into. And that means that I have to give a much larger dose to a neonate than I would to an adult to get the same exact blood concentration. So, and again, an equivalent dose to get the same serum concentration for a neonate would be 4 to 5 milligrams per kilogram versus for an adult, maybe only 1 to 2. Okay, and that only has to do with the volume distribution. It's not how they're processing the drug or anything like that. This just has to go to how far distributed that drug actually gets. That can make a difference, right? If you're treating, bacteremia, you want that drug to be in the blood, so you have to give a much larger dose for that neonate in order to achieve the same concentration. This is also really important to monitor for as kids are getting older, right? So again, if you're having, say, long-term therapy, you have to make sure you're readjusting based on their weight as they are continuing to grow, or not grow as the case may be. Also, as they get older and that volume distribution starts to change, you'll make sure you're readjusting those doses there. Again, every single Monday, I usually get those orders that come across from the NICU while they're going through and they're readjusting the dosing weights for all those neonates. And again, you have to readjust a lot of these drugs based off the fact that they're changing all the time. Their weight's usually gone up in a lot of cases, maybe gone down in some not so great cases, but you have to make sure you're readjusting for this stuff. So that makes sense? Why you have to give a bigger dose from a milligram per kilogram standpoint than you would for an adult, based off of that volume of distribution. Yeah. So other things that are affecting this, they have decreased plasma proteins. They have kind of less protein in general, less muscle mass to consider there. And not only that, you have to consider things like other endogenous products may be competing for the same binding site. So for instance, they have a lot of bilirubin. They can be competing for the same binding sites on things like albumin. That can make a big difference, right? And again, you can actually see some big issues where if you have other drugs that can come in and interact with that and maybe kick it off of the protein, you can end up seeing things like jaundice that can develop there. Then we know a particular antibiotic you don't want to give in the neonatal period because of this issue. Ceftriaxone, right? It's a third-generation cephalosporin. Really good because it treats a lot of different infections. You cannot use it, though, in that first 28 days of life because you will induce jaundice, or you have a chance of inducing jaundice in those kids because that bilirubin is going to get kicked off those proteins there. Because, again, they have less proteins overall than an adult might. Other cases here would be something like phenytoin. What do we use phenytoin for? For seizures, right? And again, this is highly protein bound. So if I had something that was competing for those same binding sites, I would have an increased free fraction of phenytoin. And that free fraction would do what? Interacts with those sodium channels, right? Block the sodium channels. You're going to find more drugs available to interact with those receptors, more toxic effect potentially. Okay. So again, that's why you always check those free levels potentially, make sure they don't have any issue with that. Okay. Again, just to give you some examples of the different protein levels. And again, I'm not going to ask you very specifically on the test, okay, which ones increase, reduce, but just know in general, plasma proteins are going to be lesser in these infants, neonates, and that this can affect the drugs, and know how they kind of affect those drugs, especially those highly protein-bound medications. Okay, getting into the actual metabolism, what are some things that can actually affect this? One, gestational age is going to be huge for this one. And again, this is why a lot of medications, you're going to be looking at what the gestational age of the patient is to determine how well they're going to be metabolizing that drug. Typically, the more immature they are when they come out, right? So the earlier they are, what do you think that does for their metabolism? It's going to be less or more? Probably less. If you had to guess, an educated guess, the more premature they are, the less functional they're going to be. That goes for excretion, goes for metabolism, any of these things. Okay. But we're going to see things like changes to the hepatic blood flow, right? If a drug gets metabolized in the liver, but they have a congenital heart defect that may be shunting blood away from the liver, what is that going to do to metabolism? The drug never makes it to the site where it gets metabolized, and it's not going to get metabolized, right? So it can stick around for longer. We're also looking at things like enzyme induction, enzyme inhibition. So these are all going to be playing a role in what are going to be affecting metabolism for these kids. So remember, we talked about phase 1 and phase 2 reactions. What's a phase 1 reaction do, kind of in layman's terms? Yeah, that's phase 0 versus phase 1 metabolism. Yeah, so we're talking about, I'm sorry, that's not really phase, but it's more 0 order versus 1st order kinetics is kind of what we're talking about there, right? So we can talk about that in a second if you need a refresher. But you know, phase 1 versus phase 2 reactions is really talking about what's happening to that molecule, right? Where phase 1 is we're actually changing the molecule, typically to either make it more water soluble or to get it ready for a phase 2 reaction. And phase 2 is normally doing what? Adding something to the molecule, right? We're adding a glucuronide, or adding a sulfur, or adding something to it, a methyl group, to make it more soluble, to make it more likely to go through renal elimination, right? So just broadly speaking, a phase 1 reaction is just changing the molecule, usually to uncover some sort of functional group to make it more water soluble, or to get it ready for that phase 2 reaction. And keep in mind, remember that not everything that goes through phase 1 has to go through phase 2. Sometimes it's just one or the other, sometimes it's both, sometimes it's neither, depending on the case. But so anyway, so again, this is where, looking at our phase 1 reaction, this is where oxidation comes into play. If you remember, what's the biggest oxidizing enzyme we talk about in terms of drugs? Cytochrome oxidase P450, remember? Remember that pesky CYP? CYP enzyme interaction is going to be mediated as oxidation pathways. So it's one of the most important ones. There are other ones, reduction, hydrolysis, etc., but oxidation is one of our most important ones we talk about from a drug interaction standpoint. But remember that different pathways may be expressed at different levels depending on the neonates and how either developed or underdeveloped they happen to be when they come out. So for instance, looking at oxidation pathways, sometimes it actually goes above what a normal adult might be doing on a weight per weight basis there. So actually in this case of phenytoin, you actually find by 1 year of age of postnatal activity, it's 2 to 5 times that of an adult. So they're metabolizing phenytoin 2 to 5 times more efficiently than an adult might. And so what do you think that does to the dose that I have to give? The decrease or increase it? Keep it the same. I would have to increase it because they're metabolizing that much more quickly. They're chewing through it so fast. I have to give them a lot bigger dose in order to make sure those levels are staying therapeutic. Okay. And again, take that into account as they're getting bigger and they're getting older and those enzymes levels are starting to go down, then you have to readjust that dose to make sure they're getting the appropriate amount, right? Otherwise, they can have the levels be too high potentially. Other examples, things like chlorohydrate. Anyone know what chlorohydrate used to be used for? It's used for an illegal activity. Anyone ever heard of slipping someone a Mickey? And again, that's not a reference to Mickey Mouse. Go watch the episode of Seinfeld if you need some historical refresher. But basically, when you slip someone a Mickey, what does that mean? Boy, I'm really outside of my age range here. But so basically, it means when you slip someone a drug to make them pass out, to do something nefarious, that is called slipping someone a Mickey. That's the term there. It comes from this story about a bar called Mickey Finn's, and this bartender basically would slip people chlorohydrate into their alcohol. People would pass out, and then he would steal their money, and they wake them up and be like, hey, you got too drunk, get out of here. And then that's how he made some extra income, right? More nefarious purposes include things like date rape and things like that. But chlorohydrate is an important one because actually when you mix it with alcohol, they both inhibit each other's metabolism, and so you end up finding that the duration of action for both of them tends to extend. They get very, very CNS depressed, very effective. However, we would like to use it in kids a lot too. Again, not for nefarious purposes, but for therapeutic purposes. So we'd use it in the NICU for a long time because it was a great sedative agent. It had a nice long half-life. Kids would stay nice and chill for a very long period of time, especially when you needed them sedate for things like, you know, if they're intubated, if they were undergoing neonatal abstinence syndrome. You guys have heard of that term before? What is that? Yeah, basically it's drug withdrawal after they've been born and they're not exposed to what the mom has been exposing them to for the past 9 or 10 months. So it's a very good drug. We don't use it anymore. It unfortunately got taken off the market. But it was nice because their metabolism made it such that it was a very good sedative agent, lasted a good long time. You didn't have to redose them all the time. And so it was good from that standpoint. Other things like, you know, procaine, tetracaine, these are local anesthetics, have an extended half-life because they don't have the same metabolism, able to metabolize it very well. So you can see cardiac toxicity, neurotoxicity, etc. So again, just some examples of things that may have to alter their doses based off of how well they're expressing these different enzymes. Anyone remember what we used to use theophylline for? Asthma and COPD, yeah. So sometimes we still use theophylline. It's actually in the same category as caffeine. Again, you'll see different metabolism changes based off of using it in the neonatal period versus, say, when they get older. So, and again, you'll find that different enzymes will mature at different rates. So some of them may peak up during, say, the first few weeks of life. Some may peak up during the first few months. Some may take several years to get to adult sort of levels of activity, right? Usually by the time they're a few years old, they should be pretty close as far as enzyme levels go to what an adult might be. And you don't have to worry about it so much. But again, early on in life is where you're thinking about these changes here. And again, you as a clinician, when you're thinking about dosing these drugs for these patients, are you trying to think about where their CYP3A4 expression is? No, you're not consciously thinking about that, but this gets reflected in the drug dosing you're looking up. So when you're looking at things like, well, why does a kid get a bigger dose on a milligram per kilogram basis than an adult might? These are things you should be thinking about. Oh yeah, it's probably because they can't metabolize it as well. They're metabolizing it too well, or whatever the case may be. Okay, so just things I want you to kind of keep in the back of your mind, that why it influences how we actually are using our drugs. Phase 2 reactions I mentioned, where you're actually adding something to the molecule to make it more water soluble, because again, the end goal is usually to make them soluble enough to where they can get eliminated through the kidneys. But this is where methylation, sulfation, all that kind of comes into play. And in some cases, kids are very well suited to some of these pathways, especially like sulfation. Like especially very young kids, first few years of life, has a great sulfation pathway. It actually makes them somewhat resistant to certain drug overdoses. So for instance, acetaminophen, normally causes what kind of hepatic it causes hepatic toxicity when the doses are too high. What you end up finding is that, usually for like an adult patient, once you start getting above like 75 milligrams per kilogram, you start to run into worries about toxicity. For a kid, they can get up to like 200 milligrams per kilogram before they really start to see any issues. They get much higher doses because they have a sulfation pathway that basically detoxifies it. So again, it's going to be on a case-by-case basis, but just know that they usually the more immature they are when they come out, the more premature they are, the less likely they are to have good expression of these pathways. Again, go through some specific examples here, but I think probably Tylenol is probably a good one there. Here's a good example of a glycine conjugation. So there's a product called benzyl alcohol, and it's a preservative. So if you ever find a product, if you look at IV vials of drugs, and you see it says multi-dose or multi-use, that usually has a preservative in it, so that way you can insert a needle into it multiple times, and you won't find any bacteria growing it because they have these preservatives in it. Well, we actually can't use benzyl alcohol in these children because they can't process it well. They don't have this glycine conjugation, so they end up developing severe respiratory acidosis or metabolic acidosis and this gasping baby syndrome they talk about. And so we have to make sure that we only use preservative-free products for these infants, these neonates. That's very important because if you actually screwed up and used the wrong kind of product for a NICU kiddo, you can end up potentially killing them. So a lot of it goes into choosing what kind of products we use based off of these different metabolic pathways. Getting into excretion, obviously, the more premature they are, less likely they are to see things like the kidneys functioning super appropriately. You're going to find that usually things like glomeruli and nephrons are going to be less functional the earlier they're being born there. But you see that things like urine pH is going to be playing a role in how well drugs get excreted, all those sorts of things. So these are things we're going to be looking at. And typically, what you find is that when you're estimating the actual renal function for a kid, it becomes pretty difficult for the most part, mainly because when they're so young, their serum creatinine can be pretty variable. And in fact, when you're actually measuring serum creatinine for the first week of life, it's actually falsely elevated. Anyone know why that is? It's actually the mom's serum creatinine you're measuring there, right? Because again, there isn't equilibration between the mom's blood and the baby's blood. When the kid first comes out, you're going to find serum creatinine seems pretty elevated. It could be like up to 1. You're like, man, this kid's kidneys aren't working that well. Actually not the case. If you wait a few days or wait a week or so, you will find it will drop back down to what their actual levels are. Because again, where does creatinine come from? Muscle breakdown. And what do we say about muscle in these NICU kiddos? They don't have very much, right? Too many baby bodybuilders coming out, and so they don't have a lot of muscle mass, and so they really don't have a lot of muscle mass to produce that creatinine in the first place. So if it looks that high, usually it's because you're measuring mom's level. So once they're born, first few weeks or so, you're going to find function is going to go up. And so again, the more preterm they are, you're going to find their GFR is going to be relatively low, mainly due to just the general immaturity of the kidneys there. Okay, and so what are some things you could do to monitor if you could say you couldn't rely on the serum creatinine? What could you use else to kind of determine the renal function of the patient? Who would you monitor for? urine output is going to be the #1 thing we're going to be looking at. Okay, so urine output, it gives us a good idea of how much urine they're producing, how well they're functioning at actually producing that urine, and so that's one of our #1 determinants for renal function for these kids. Okay, and we know like a normal urine output should be for these kids. Usually, what we're looking for is anything above 1 ml per kilo per hour. For like an adult patient, if you're measuring their urine function, usually between 0.5 and 1 is considered normal urine output, mLs per kilo per hour. But for some of these babies, especially when they're first born, usually they end up diuresing. First couple of days of being born, they can be shooting out 2, 3, 4, 5, 6 mLs per kilo per hour. So sometimes urine output can be very good from that standpoint. It should normalize out though after a week or so. So, and again, just to give you some ideas of looking at the GFR, if you're actually to measure and compare, say a preterm infant, so say less than 1,500 grams versus one that's say less than 2,000 grams. And again, 2,000 grams is how many kilograms? 2, right? Remember, you'll be able to do those interconversions pretty easy in your head, versus term infant. And what you notice here is that when you look at these preterm kids, even by the time they're 2 weeks out, they're still not even close to what the term infant was in terms of renal function. So it can take some time before they're actually functioning appropriately from that standpoint. It could take many months before they've kind of caught up, so to speak, to where the term infants would have been at that point there. Okay, so just some things to consider, and that's why the drug dosing is so different based off their gestational age, and why those references make the distinction between those. Okay, and again, just to give you an idea what GFR should be in these kids here, so say the neonatal period, maybe 30 to 40 mLs per minute. As they get older, around 6 months to 3 years or so, you should be getting pretty close to adult levels there. Okay, so at that point, you can kind of consider renal function to be pretty similar. We'll still measure urine output for these kids as well. And how do you measure urine output like in a baby? You have a catheter and you can collect it directly. That's one way to do it. What else could you use? You can actually weigh the diapers, right? So again, if you know how much the diaper weighs by itself, and then you take the dirty diaper, you can basically see how much volume of fluid they're releasing out based on the weight there and determine what the urine output is. Again, that's another way you can actually measure that. Some of these diapers can get so heavy, so gross. Okay. So just to give you an example of how we have to modify the drug dosing for some of these medications here, we're looking at gentamicin, right? And we said you already need a bigger dose on a milligram per kilogram basis based off their distribution. Well, let's look at how we actually are affecting the half-life based off their renal function. And what you see is the neonate less than 1 week, 3 hours to 11.5 hours half-life, versus an adult maybe 1.5 to 3. So that means that to get the same drug levels for an adult patient, I'd have to give her a bigger dose because the volume distribution is so much higher for a neonate. But what do you think I'd have to do to the dosing interval? I'd have to increase the interval, right? So I'm decreasing how often I'm giving the drug by giving them a longer interval between. So say for instance, and we don't normally do Q8 dosing anymore of gentamicin, let's say for an adult I was giving Q8 hour dosing. To get the same levels as I would for a neonate, especially a premature one, I may have to give it every 24 hours, or every 36 hours, or every 48 hours. Okay, make sense? So again, I'm giving a bigger dose on a milligram per kilogram basis to account for the volume and distribution changes, but I'm giving it much less frequently to give them more time for that to clear out of the kidneys before I dose them again. Because again, if you remember when you were looking at the toxicity, it's the high troughs that were really the problem. When you're holding onto that drug for a good long time, that's what led to the ototoxicity and the nephrotoxicity, right? So again, factor in that the dosing is not just the dose you're giving them, but also how frequently you're giving it. Okay, make sense so far? Again, renal function might be an important thing to consider, especially for, say, for instance, your homework assignment. Not that I would know about that, but looking at things like secretion and reabsorption, typically it's immature in the early stages of life, especially if they're more premature. I just know that can affect things like renal blood flow, can affect things like urinary pH levels. That can all affect how well drugs either get reabsorbed or secreted. And again, that will be taken into account when you look up this drug dosing online. All right, so any questions so far? It's all a good review. It's all coming back to you, hopefully. Maybe like a PTSD attack, perhaps. It's okay. It's okay. Right. So again, diving into a little bit about the diversity in drug response these kids are going to have. We know there's a ton of different things that play a big role here. So, for instance, think about things like polymorphisms and how they can play a role in how patients are going to handle their drugs. Right. So, for instance, we talked about CYP2D6 playing a big role in which particular medication? Codeine, right? Codeine playing a role with getting turned into morphine via that CYP2D6 polymorphism, or that CYP2D6 enzyme reaction, right? Metabolizes codeine into morphine. So people that have a hyper rapid metabolizing set of enzymes is going to be able to metabolize a lot of that into morphine. They get a very good drug effect from it, versus those that don't may not get a whole lot of effect from it. And of course, having too much of a good thing can be a bad thing. So to produce too much morphine, we were seeing some of those kids are actually dying from that, especially if they were post having their tonsils taken out, and they had OSA, all that good stuff. We talked about that. But, and again, that can go into showing, like, okay, what drugs are we going to use for these kids potentially? And so that basically, once those reports are coming out from the FDA, we basically said we're just not going to use codeine at all for these kids anymore. Does that mean codeine's a useless drug? No, it's not a great drug, but it's something that we're just not going to use in pediatrics, and that goes into why that is. Because if you sometimes go, well, how can we use this drug versus that drug? That there's usually a reason why it has to do with something like that. Just like we don't use ceftriaxone in kids less than 28 days, because we know there's going to be that bilirubin interaction. They can develop that jaundice. There's certain reasons why we use certain drugs for a particular patient subset than we don't use for others. Again, a lot of it can be traced back to either the kinetic variations or the dynamic variations, whatever the case may be. So again, as I mentioned, the CYP2D6, that's a black box warning on it now, because we know for codeine that if you have an ultra rapid metabolizer, they're going to make too much morphine. That could be a big risk for things like respiratory depression, right? So getting into actually the dosing regimens, we talked about this briefly. What's kind of the best dosing regimen you can use for a kid? What's the safest thing we can do? The age-based, weight-based, astrological sign-based. If you're a Capricorn, you get this much. Weight-based is typically going to be the most common. It's going to be relatively safe compared to other things. So for instance, if we use age-based dosing, which you'll still see this on occasion for especially older drugs, you're going to see this in the references. What's the drawback of using age-based dosing strategies? Some kids are really big for their age. Some kids are really small for their age, right? See some kids who are 16 that weigh 50, 60 pounds, right? Because they have these chronic conditions where they are just extremely small for their size. And again, it assumes that the absorption, distribution, all the kinetics are the same across all these kids, depending on their age. We know that's not always going to be the case there. It's easy from a drug memorization standpoint. Remember, if I have a 3-year-old, I'm going to dose like this. If I have a 6-year-old, I'm going to dose like this. But again, it could maybe paint too broad of a brush, or paint with too broad of a brush, and kind of categorizing the kids and assuming they're all the same, they fit into that age category, which we know is not the case. The body weight is going to be the most common one. Again, be very, very careful when you're looking at your dosing units. This is especially important when you're dealing with a lot of electronic medical record systems, because oftentimes it'll pre-populate in what the units are, and if you're not looking, you can very easily get a big error happening. So for instance, I was talking about the anesthesiologist who was trying to write for 25 micrograms of fentanyl for a patient, but did not realize that the units were stuck in micrograms per kilogram. So when you wrote 25 in that little box and it was set at micrograms per kilogram, guess what? That's a heck of a lot bigger dose than you actually wanted to get. It's like 2.5 milligrams of fentanyl, which I think would probably be enough to kill this entire room. So you have to be really careful. And of course, the call was, hey, do you really mean to order like 2.5 milligrams for this one patient? And they're like, oh gosh, no, I did not mean that. And so we got it fixed, of course, because you don't want all the Swiss cheese holes to line up. But that's a very important thing to consider. Very easy to kind of get into a pattern when you're using all these computer systems to click through stuff. Gotta be really careful and look at those warnings when they pop up. You guys ever heard of alert fatigue? You know what that is? It's basically what it sounds like, right? You hit a button and it comes up with the box, hey, look at this big warning. You're like, I don't really care about that. Click. And then another warning pops up. Hey, this interaction's happening here. I don't really care about that. Click. And you click, and you click, and you click, and you click. Eventually you click through everything, right? And so this is a big deal, because providers will sometimes go past big red lights to say, stop doing what you're doing, because this interaction could occur, this error is happening here, and they'll just click right through it, because they have this alert fatigue. They assume every alert is nothing, right? And so that's one of the big things that we focus on, at least from a drug standpoint, is trying to make sure that the alerts that you get are actually clinically relevant. They're things that actually are going to make a difference. Otherwise, you can just click right through it, right? You get too many of those alerts, okay? It's kind of like getting like spam messages on your internet browser if you don't install an ad blocker or something like that. You just kind of get blind to a lot of those things. And so it's really important to make sure you're kind of keeping in mind, like, hey, some of these alerts actually mean something, you should take a look at them. Anyway, but yes, weight-based dosing is probably going to be the most common thing. What's an important thing to consider, though, when you're trying to dose a kid? So they come into the clinic, what do you need? You need an accurate weight on the child, right? That sounds pretty easy. Put them on a scale, they're good to go, right? Kids usually all that cooperative. I try to put my 2-year-old, I say, stand on that scale until it's done doing its thing. what's she gonna do? Hop right off and go run around, jump back on it, jump off, and run around. You know, so again, it can be sometimes difficult to get an accurate weight. Oftentimes when we're, because me and my wife are nerdy like this, we like to make sure we have accurate weights on our kids. So every couple weeks or so, we're going to do it. So basically, what I have to do is I have to stand on the scale by myself. I have a pang of shame spread through me, and then I use that as my baseline, and then I grab one of the kids, and then we, you know, subtract the difference, and okay, now, you know, Phoebe is 20 pounds and whatever, right? So again, depends on what you're doing, and make sure you're getting accurate weight there. Because a lot of times we'll have kids that will come into the ER and they'll say, hey, you know, what's the weight of the kid? And the mom's like, 20 pounds. Like, well, when was that done? Like, could have been 6 weeks ago. The kid could be a much different weight now, based off of the base. Especially the younger they are, the more rapid changes you're seeing there. So you got to make sure you're getting an accurate recent weight. And in fact, I'll give you an example of how system-wide this can be a problem. We ended up having beds that were put into the ER initially at Nemours. We bought these nice beds that have scales already built into them. You're like, wow, this is really great. We can weigh the kids right there on the beds. Well, guess what? There's usually an operating range on those sorts of things. And if you go below the operating range, you can't guarantee that's an accurate weight. Guess what the weight limit was on the low end of that bed was? It's like 50 kilograms. It was made for adults. So again, a lot of our patients, guess what, are below 50 kilograms. Some of them are weighing less than 1 kilogram in some cases. So you have to be aware of that and know some of the limitations seen with some of that stuff. Also, as well as when you describe your weight to somebody being or living in America, to use pounds or kilograms. Probably use pounds, right? A lot of your notes you're writing, you're probably using pounds there. Again, what is most of our dosing that you see when you look up the stuff on lexicon? Based on kilograms, right? So you got to make sure you're using those interconversions appropriately, because otherwise you can get into some big errors there, right? So either usually a 2.2 times error, either underdosing or overdosing. And again, to get from kilograms to pounds, well, how do you convert it? Multiply it by 2.2 to get from pounds to kilograms. You divide by 2.2, right? And I've seen some big errors that happen with that when either people are using pounds and they think that someone's referring to kilograms. That's why it's always important to say your units when you're communicating some of these things. Hey, the patient weighs 20. 20 what, right? You got to make sure you're being very explicit with that sort of stuff. Okay. Anyway, other things you're going to find with the body weight dosing is that, again, we're finding an increased incidence of obesity in children, and so you're going to find that when they have this extra body tissue, it could be a lot of fat tissue, and that's affecting the volume distribution. You maybe find that you're actually overdosing based off of their pure weight, and so in some cases we have to use things like adjusted body weight. I'm not going to get super deep into that right now, but just know that you're going to find that some of these dosing may not be appropriate on a strictly milligram per kilogram basis. And again, when I'm dosing, say, a teenager, and if a teenager comes in and they weigh 240 pounds, what is my limit? Like, when do I cap off that weight-based dosing typically? Usually when they get up to the adult doses, right? Once they hit that adult dose, I don't really want to go beyond that. And so it's an important consideration to make, right? So for instance, if a kid is supposed to get 15 milligrams per kilogram of Tylenol, but their dose goes above 1 gram, I'm typically not going to give more than a gram because that's a normal adult dose, right? So again, that should be your cap as far as the upper end of what that dosing strategy should be, okay? So you just don't go straight off weight per kilogram, milligram per kilogram and say, okay, well, they need 3 grams of Tylenol for this dose. No, they don't really need that much, right? Just cap it off the adult dose. Other things we can do is body surface area. Now again, we did an example of that, I think, we were doing one of the chemo meds, right? And so again, body surface area incorporates what 2 factors? Height and weight, yeah, exactly. So again, this helps to mitigate some of the big differences you can have in patients who may be very heavy or very light for their particular height, and so that takes that into account there. So most of the time you're going to see this often with chemo drugs. You're going to find this with some other medications like corticotropin and things like that, but really it's just important to make sure you are getting an accurate height. And again, just like getting a weight can be sometimes difficult depending on the kid. Getting an accurate height can be difficult as well, especially like little babies and they want to kind of move their arms and legs around. You got to try to stretch them out, to make sure you get an accurate height there. It can be important. There's a lot of different types of calculations, so just make sure you're using a consistent one depending on where you're working at. Okay, so looking at IV drug administration, so important things to consider are going to be things like, okay, where's the actual site? Like, where are we actually getting our IVs at? As I mentioned, kids having smaller veins, they typically be a little bit more delicate, right? It's harder to get the IV started. It's easier to blow the veins, easier to extravasate the drug, right? Extravasate just means what? A drug going outside of the veins, which can cause significant tissue damage depending on the drug that you're dealing with. Also consider things like the volume of drug that you're administering, right? So again, some of these kids, giving a normal, say, adult sort of volume of drug, to them may be a ton of extra fluid, right? And all that fluid can do things like throw off your hemoglobin, it can throw off, cause, electrolyte changes, it can throw off a lot of things if you're not careful with it. And so you have to think, okay, well, I want to get drugs more concentrated. Typically, that will help to save volume. That can be good to a point, but again, sometimes you're going to find there's limits to that, because once a drug gets too concentrated, it goes out of solution. So oftentimes you have to make sure you're using the right standard concentrations and things like that, make sure you're actually getting a workable volume there. But also, if we get drugs that are down to, some of our NICU kiddos, we're getting doses that the volume is like 0.02 mLs. How easy is it to measure 0.02 mLs? It's very difficult, right? The syringes that we're using are not really designed to go that small of a dose, and then even then, you'd have to think about the dead space in the needle itself, or the dead space in the hub of the needle. You have to factor that into it, which may be more than the actual dose would have been in the first place. You guys know what I'm talking about when I say like dead space? You imagine like measuring a needle, and you have that space that's filling that. That's not a drug the patient's going to get, but you have to factor that into the actual how much you're drawing up. Anyway, but just things to consider there. Also, get things like multiple drugs and the corresponding frequency. So again, like how often am I giving these drugs? I'm giving them all together. Is that a big fluid bolus for them potentially? It can be really important. And of course, there's just mechanical technical issues, right? So think about what kind of access you have. Do you have central access or not? When I say central access, what does that mean? So peripheral means you're getting access usually like an arm or some kind of peripheral vein, but if I say central access, it usually means I have a catheter that's going into and usually dumping out in the vena cava. What's the benefit of having central access? It gets diluted very quickly, right? Because the blood flow in the vena cava is much higher than you would see in, say, something like the AC. So by doing that, you're able to dilute out drugs more. I can usually give higher concentrations. I can usually give drugs faster because they get diluted out more easily. You get to the central circulation much more readily. So when I say central access, that's what I'm referring to. And so you'll frequently find that, especially for things like electrolytes and different types of medications, that some of these things are, central access is required, or you can give different doses and things like that. A good example is something like a vasopressor. When I say vasopressor, what does that mean? Causes vasoconstriction, usually to raise blood pressure. Okay. Well, if I were to give something like, we'll talk about these later, but something like dopamine, right? Dopamine is a vasopressor, it's a vasoconstrictor. If I were to give that to a peripheral vein, what is that going to do to that vein? It's going to compress it, and you may find decreased blood flow, right? So it's one of those things where by giving it centrally, I'm able to get it diluted out more quickly, it's able to get it to the central circulation much more readily. And so you can actually use higher doses, higher concentrations when using centrally administered drugs than you can peripherally administered drugs. So just an example of something to think about when you're actually giving these drugs and what that entails. Also think about things like therapeutic drug monitoring. Oftentimes we have to factor in how much blood we're taking out from these kids, because you can actually, especially for NICU kiddos, we try to take as small a volume as we can, but the machines have certain limitations on what they need to run certain tests. And so oftentimes we want to make sure we're sampling everything off as small amount of blood as possible. Otherwise, you can definitely see drops in their hemoglobin when you're doing frequent drug or frequent just lab sampling in general for some of these kids. So just something else to think about. And again, how do we make sure that we're getting a very accurate amount of drug into that patient? Kind of just like hang something to gravity and just say, I'm just going to let it run in however it runs in. No, we want to be very exact when dealing with these kids. And so very frequently, we're going to have things like pumps that will help us to administer very exact amounts of drug to the patient there, right? And oftentimes these are built with libraries in mind. I think of an example here. Here's a syringe pump that we have that will allow us to administer very exact doses and volumes to that patient. And basically this machine has a little thing here that can actually detect how big of a syringe you're hooking up, and then based off of this, it will then be able to push that plunger in to administer exact volumes of drug to that patient there. And the nice thing here having this electronic system is we have libraries that are built into it to make sure we're not hanging just anything, but we're actually putting in things that are the right doses, the right concentrations, the right volumes, and everything like that to make sure we're ensuring patient safety, right? Because again, medication administration is one of the most fraught things you can do to a patient where an error could occur. You have to really be careful when you're doing that. Now again, how often do you think you guys are going to be the ones actually hooking the stuff up to the patient? Not frequently, right? But you're going to be one making the orders, and the nurses are going to come up asking questions like, well, this machine's giving me an error. It says I can't run this dose. How come? And you may need to be able to reply to that. So some of it could be related back to the library and then not being able to run it appropriately. Or you just say, just call the pharmacist, they'll figure it out, right? Anyway, looking at oral administration. So again, how do we traditionally measure out drugs for oral administration? Like teaspoons, tablespoons, right? And so again, depending on where you're getting your spoon from, that can make a big difference, right? How much is a teaspoon? How much volume is a teaspoon? 5 mLs, okay? How much is a tablespoon? 15 mLs, okay? It's a good round number to keep in mind. So when someone says, I gave them 2 tablespoons, you'll know roughly how much volume that is. But again, if I go get my spoon from Walmart, my tablespoon from Walmart versus one I get at IKEA, you may actually find the volume differs pretty greatly there. In fact, and even this is a kind of a pet peeve of mine, but we got some like liquid medications from CVS or somewhere, and they have a little dosing cup, right? And so it says, okay, pour it to this line. This is 5 mLs. I said, I'm going to double check that to make sure it actually is 5 mLs. So I poured it up to 5 mLs, and I had a dosing syringe. I pulled it up, and it was like 6 mLs. And I said, that's drug errors happening right there. It's medication errors. But anyway, so again, make sure you're having an accurate measuring device. If you're sending them out to the pharmacy, chances are they will have dosing syringes that will be available for them to pick up and use. That's the most accurate way to give these doses. And when we do our calculations for our prescription assignments, how do you dose it? What do you write on that prescription? You write the volume, right? You write how many mLs you need them to take, not teaspoons, not tablespoons, just write mLs. And I think a lot of people are now getting into the habit of that. It's much more easy, right? And again, how exact do you need to be for these oral doses? Probably to the 1/10 of an ml at most. I would never go to the 100th. That's just a little too complicated there, too hard to measure. And again, think about the dosage forms. A lot of kids, especially younger ones, are not going to be able to take tablets. Or you have to think about the liquid medications, and especially like think about certain cases where you can't use certain types of liquid medications. Usually, liquid medications contain a lot of sugar, and usually contains lots of dyes. So if you have someone who has a dye allergy, guess what? They can't take that liquid anymore. You have to find an alternative. If they have, say, they're on a ketogenic diet. It's a ketogenic diet. It's good for CrossFit, maybe. No, it's good for kids with seizures, right? And again, we try to make the body more acidic by putting them into a state of ketosis by giving them no carbohydrates or very little carbohydrates. And so if the medication has a bunch of sugar in it to make it more palatable, that's going to throw them out of ketosis, and that could be bad, causing precipitate seizures. So little things we have to think about. Again, the sensory appeal, that can make a big difference. What's the taste of it? What's the flavor? Even the color of it. Some kids will look at it and they're like, I don't want to take that. That's red. I'm not going to drink red stuff. Well, okay, whatever. I guess that's your thing now. Cool. But think about inactive ingredients, all these different things that factor into that, right? And again, when you're prescribing, obviously get the most current weight possible if you can. Sometimes you can't always get the most accurate weight, but do the best you can. And again, check with those available references. Always look something up if you're not sure, especially if you've done it a million times. It's a good time just to look it up anyway, just to double check yourself. And then obviously with counseling, talk to your audience, right? So again, if it's a 2-year-old, like obviously you can't really educate them a lot on what they're taking, why they're taking it. Talk to the parents, right? If they're a little older, be able to communicate with them, say, hey, this is why you're taking this, is because you have an infection, blah, blah, blah. But again, just know your audience. Okay, so again, I'm not going to go belabor these drug dosing calculations because, again, I feel like you guys are pretty well practiced at this, right? Again, but what are some of the caveats we have to remember here? One, always look at your units, right? Remember, does it say milligrams per kilogram per day? Does it say milligram per kilogram per dose? Does it just say milligram per kilogram per day divided BID? Right? Remember all those things. You have to really look at that hard because, again, we get errors like this all the time that come up where they don't look at it appropriately and they're giving either too big of a dose too infrequently, they give too small of a dose way too frequently. All these things can happen here. Right? Very common drug errors that occur here. Right? You want me to walk you through all the steps again? You feel like you're really well versed in this stuff. And again, that's why I try to make such a big habit of pushing this early, so that way you guys feel very comfortable writing for these liquid medications for these kids. Because that was a complaint we got early on. It's like, hey, we don't really have a lot of experience with this, and that's why I try to push it more now. Anyway, but again, you can work through these. Again, we do a lot of examples of this. I'm not going to belabor the points here. But again, always try to get down to that final volume, because if you tell the parent, hey, go ahead and give them 420 milligrams of a drug, like they're going to say, I don't know what that is. Like, can you do the math for me? Figure out the volume they're going to actually need there. Okay. Anyway, again, this is a good example of, is the drug being dosed in, and again, this always kind of is a pet peeve of mine, but when it says like, acetaminophen, 160 milligrams per 5 mLs. Now, where does that per 5 mLs come from? This is the teaspoon, right? The teaspoon dosing we used to use there. And so again, you have to kind of break it down into what the actual individual per ml amount actually is. So for instance, acetaminophen is 32 milligrams per ml. Now, how come we don't have a bunch of different varying concentrations? Why do we always have just one standard one for a lot of these drugs? Because there's a lot of errors that happen there, right? And there used to be multiple types. There used to be infants Tylenol, there used to be children's Tylenol. And there were different concentrations there. What do you think was the problem? What the mom came and said, hey, I was giving him 5 mLs of Tylenol. You didn't know how much that actually was. Was it the infant kind? Was it the children's kind? So by consolidating a lot of those and just making one standard concentration, it makes it the same across the board. So that way it doesn't matter which hospital I go work at, which CVS I go to. I know that all the liquid Tylenol is going to be 32 milligrams per ml. That may not hold true if I go to a different country, but here in the US at least, that's what our standard is. And so again, from a safety standpoint, it's good to be as consistent and standard as possible. Okay. So anyway. So we already talked about those. Again, remember fluid calculations. This is important as well. So when you're trying to dose patients for these things. Now, I know some people are like, well, I need to wait for this last prescription assignment. I need to figure out how much this patient weighs in order to get a volume amount. Anyone find any like kind of standard adult maintenance rates for fluids? So I will tell you this. So again, this is why we practice these things, right? And I haven't looked at any of your assignments yet. I need to work on that. It's only been a few days. But I was like, well, this is obviously a standard number that everyone knows this number. Obviously, it's got to be all over the internet. You got to be able to find this number anywhere you go. And you know what I did? Actually, I looked it up myself. And you know what I found? I couldn't find that number anywhere, to be quite honest. I was like, wow, these guys actually have a legitimate complaint about this assignment. I'm so glad they brought this up so I can correct it for next time. But it's one of the things, sometimes like you have this medical dogma that just like enters your head, and we have this number. I have no idea where it comes from. Actually, I do kind of know where it comes from. But basically 125 mLs per hour is like a standard adult maintenance rate. And you kind of use that as your standard. You can go off of that. But again, it's always nice to do specific calculations if possible, and you can't really go wrong with 4-2-1, right? My main goal of not giving you a weight in that assignment was to try to make sure you're just using standard doses and not trying to get too granular with the things. So like if you're writing for Zofran, just write for 4 milligrams and not try to get much more specific than that, because it's not really necessary for a lot of adult stuff. But for fluids, you can always try to get exact as you want, and 4-2-1 will steer you right in 99% of cases there. Just remember, fluid balls, 20 mLs per kilo, the very standard fluid balls. What's usually kind of the upper limit of that we'll give? Usually 1 to 2 liters, okay? Especially for kids, like we usually don't go above the 1 liter, because with fluids, what's the general rule of thumb? I can always give more. It's really hard to take it back. How do you take it back? Either get it out in the urine or put them on dialysis. Either of which is going to be very time effective, and dialysis is not something you want to have to do on accident because you fluid overloaded the patient, right? So you can always give more fluid. So usually for kids, we're going to cap out this 20 mLs per kilo at 1 liter. Now again, this depends on the clinical circumstance. So they're coming in, they're actively septic and hypotensive, tachycardic, you may give up to 2 liters, right? If they come in, they're a trauma patient, they have a huge volume loss, you may need to give much more than that. But for most patients, coming gastroenteritis, migraine, whatever, 1 liter is going to be fine as an upper limit for most of those kids there. Okay, and then we have the 4-2-1 rule. You guys are familiar with that. For the first 10 kilos, the patient's weight, they're going to get 4 mLs per kilo per hour. This is the maintenance rate, so it's in mLs per hour is going to be the final unit you get to. The second 10 kilos, you're going to get 2 mLs per kilo per hour, and then for every subsequent kilogram, they get 1 mL per kilo per hour. Okay, so you should feel comfortable being able to calculate those. There may be a question on the exam. I haven't written it yet, so I'll have to find out if there's going to be any questions like that, but you should be prepared to do that if need be, right? Again, for instance, if I had a 45 kilogram adolescent, how much is their maintenance rate? So it's going to be 40 mLs per hour for the first 10. It's going to be 20 mLs per hour for the second 10. And then I have 25 mLs left over. Add that up together, we get 85 mLs per hour. Okay. And again, if you practice it and you look at different weights, you'll be able to come up with it very, very easily. And again, we do this all the time. Almost every patient gets admitted that's NPO, they're going to be getting fluid rates, and so we double check this every single time to make sure it's appropriate. Anyway, again, another thing to consider as well, when I say 1% solution, what does that mean? It's kind of an old archaic way of listing things, but you'll still run into this all the time, especially if you work in surgery. We'll talk about 1% lidocaine. You're going to talk about 1/4% bupivacaine, all these different things. Basically, it just means that it's 1 gram per 100 mLs, or if it's 1/4%, it'd be 0.25 grams per 100 mLs. And so the easy way to convert that, anyone remember the trick to get the easy concentration? You just move it over 1 decimal place, and that will give you milligrams per ml. So if I have a 1% solution, I want to convert that into milligrams per ml, just move the decimal place over 1 to the right, and I know it's going to be 10 milligrams per ml. If I have 1/4% solution, if I have 0.25% solution, how many milligrams per ml is that? Move it over 1, 2.5 milligrams per ml. Okay. I mention these because these are really common ones. If you work in surgery, you're going to run into these local anesthetics, and they're dosed in percentage all the time. So if you need to know what's the max amount that I can give, a lot of times it's based off this milligram per kilogram amount, and you'll be able to do that conversion pretty easily. Okay. Anyway, so I've done this before, so I'm not going to belabor that point. But any questions so far, based off the general stuff? All that was a review. Let's get into some specific examples of cases where we're using these drugs a little differently for these kids here. So first off, I want to talk about neonatal medicine, mainly in sort of the NICU sort of realm. And let's start off with neonatal sepsis. So typically when considering neonatal sepsis, we're kind of considering this to be as bacterial infection within the first 90 days or so of life. And again, which kind of neonates do you think are going to be more prone to these infections than others? What do you think are some things that will predispose them? Maybe the more premature they come out, because again, is their immune system super competent when they're born? No, typically they're fairly immature, and again, the more premature they are, the less competent their immune system is going to be. So typically you're going to find they're going to be much more likely, especially if they're not able to really mount much of a defense against these bacteria here, the viruses, whatever the case may be. Typically, you find neonatal sepsis comes from kind of three main routes. Either it can be intrauterine, so they kind of pick it up from mom. It could be a perinatal acquisition actually during the delivery itself, or it could be hospital acquisition, right? And I always talk about how hospitals are the worst place to get healthy. You typically are going to get lots of bugs live there. You don't want to necessarily pick those up. And again, some risk factors: gestation less than 37 weeks. That's really any premature infant. There is going to be a risk. You have a premature rupture of membranes, etc. All these things could be potentially putting them at risk. The other big thing to note here as well, because this is important for mom, is do they have Group B strep, right? Or they have a history of Group B strep. Having an infant with that, and we'll talk about some prophylaxis we can give to mom as well. So kind of talk about her briefly. So one of the big things I want to note here as well is that, because this will dictate what kind of drug therapy you're going to use, is whether it's early onset or late onset neonatal sepsis. Okay, early onset just means it's going to be within that first week of life or so, and then late onset is going to be anything up to that 90-day mark. Okay, and so this is important because the organisms change pretty greatly depending on which, if you're looking early versus late. Notice here, Group B strep is probably going to be the biggest ones you're going to see, especially if the mom did not receive prophylactic antibiotics and she was positive. You also see things like E. coli, and then Listeria is an important one here. We'll talk about what the drug of choice for Listeria is. It's a good thing to know. Anyone know off the top of their head? Close. Not amoxicillin, it's another aminopenicillin. Ampicillin is actually going to be the thing we focus on. Again, I'm talking about these kids are going to be coming in, you're evaluating them for sepsis, looking at their postnatal age, kind of figuring out where they're at, and then you'll be choosing your antibiotics based off of how their presentation is. But Listeria, we're talking about ampicillin is going to be the drug of choice for Listeria. And then, looking at a little bit later on, this is where things like, E. coli can be coming up, staph, Candida even potentially from a fungal standpoint. And so typically when they have these early onset, you're going to find it's more just kind of general bacteremia. Late onset, you may see more of a focal infection like meningitis or pneumonia, something like that. Okay, that kind of all gets lumped into this general sepsis category. So as I mentioned, looking at for early onset sepsis, the predominantly the way we're going to be treating this is with empiric therapy. And again, based off of cultures, we may be able to narrow it down. And again, sometimes you have kids who come in that you don't have a known infection, but you kind of ruling other things out. You're going to put them on prophylactic antibiotics anyway. So a lot of kids will be on these for what we call a 48-hour rule out, where you put them on it 48 hours, kind of see how they're responding. If they kind of resolve on their own, you may be able to take them off antibiotics early, especially if you don't culture anything out, the white counts are looking good, all of that. Basically, the two drugs we're going to give them are going to be ampicillin. This is predominantly to get the Listeria, along with some other gram-positive coverage, and then we're going to have Gentamicin. Now remember, the Gentamicin dosing is going to be very dependent on several things. So again, what's their gestational age? Because we know the kinetics are going to change pretty greatly there, whether they need to get it, say, every 24 hours. Some kids will need it every 36, every 48. One important thing to consider, especially if you're working at somewhere like Nemours, do we have a lot of babies being born at Nemours? Anything with the hospital, we have 0 babies being born at Nemours because we don't do L&D, right? We're just for kids, freestanding children's hospital. Versus if you were at ORMC for APH, you see a lot more kids being born there, right? So that's important because we don't have any kids necessarily being born there. We have a lot of transfers that are coming in. And so when you have these transfers coming in, the important question is to ask, what did they get at that first hospital? And oftentimes they will have already gotten antibiotics, and that's important because you need to figure out what time to start the next dose. And so they should be getting every 36-hour Gentamicin. They got a dose at the outside hospital. You need to figure out when then you're going to need that next dose, because if I give it too early, what can happen? toxicity can happen because they're building up levels. If I give it too late, what can happen? The infection isn't being treated appropriately, they can continue to get worse, right? So timing can be really important, especially for these drugs that are given very infrequently, right? Maybe every 2 days in some cases, depending on how premature they are. And then typically, if they're going to remain on it past that 48 hours, go ahead and do 10 days worth of treatment. Usually pretty standard. For late onset sepsis, some of the things that may be predictive of kind of more serious issues with them include things like, if they're low birth weight when they came out, they've had any sort of like seizures and any kind of other focal findings associated with this, especially if they have to get intubated. Usually they end up doing a lot worse than kids that don't. And for their empiric therapy, we're going to find that we're going to widen out our coverage quite a bit. So instead of just using ampicillin and gentamicin, we're going to be focusing on much more broad spectrum coverage. So an example of this would be something like either ampicillin or vancomycin, which are going to be good for covering what? A lot of gram-positives, right? So again, getting some of that staph, getting some of that, and again, if you're really strongly suspecting staph, you're going to find ampicillin's not necessarily going to cover that, but get some of those gram-positives, and then plus something like gentamicin or cefotaxime. If you remember, cefotaxime is what generation cephalosporin? It's actually a third, right? Now again, you say, well, third generation cephalosporin, why can't I just use Rocephin? If they're in that first month of life, you do not want to use Rocephin because you worry about the bilirubin issue. Okay, now if they came in there later than that, then that would not be as big of an issue. But normally what you'll find is we use ampicillin and cefotaxime is probably the more common combination I find, and that gives you good coverage. Now again, normally you think like, well, why would you use ampicillin, penicillin plus a cephalosporin? But again, the ampicillin is going to be good for covering any listeria that may be there. Not as big of a risk for that late onset, but still something you can consider covering for. And cefotaxime kind of gets a lot, pretty broad coverage for gram-negatives, some staph, things like that. And again, depending on the where the infection actually is, if it's just bacteremia, 10 days is usually fine. But why do you think I shoot for longer treatment times for meningitis? It's hard to penetrate that blood-brain barrier, right? So again, what you're going to find is that with meningitis, certain antibiotics are able to cross more easily than others. But one of the things you find is that early on, when the meninges are nice and inflamed, what happens to those gaps in the blood-brain barrier? They typically get bigger, right? But as they start to get better and the inflammation goes away, they start to get more narrow, and it could impede antibiotic penetration there. So usually treat for longer. Make sure you try to eradicate all of that because we know it's harder to cross that blood-brain barrier and really get good antibiotic penetration. Now, the best thing you can do for a lot of these kids is try to prevent maternal group B strep. And so basically they tend to get screened around 35 to 37 weeks. Again, some people have already had their babies before this, but typically 35 to 37, they're going to go ahead and get screened for that. And then, as the case may be, they will get intrapartum antibiotics. Okay, again, they get screened, they're positive, they'll go ahead and get these intrapartum antibiotics. And so basically, and again, other things that may predispose you to go ahead and giving these anyways, if you have, obviously, if a positive screen, yeah, you give it to them. But, they have other risk factors. So, again, if they had rupture membranes greater than 18 hours, they had fever or prolonged or short gestation, any of those things would just say, let's go ahead and just give it just in case, just because the risk kind of outweighed the benefits at that point. And so what they would recommend for those patients would be just penicillin G is actually pretty good for covering for that group B strep. You can give an IV loading dose, and then you basically give a dose every 4 hours or so. Why do we give penicillin so frequently? Remember, it's a time-dependent antibiotic. Remember, we were talking about time versus concentration-dependent. You guys remember that? Anybody? No? Okay. Well, remember, we have to keep it above the MIC for any bugs that are there to try to keep them from replicating. So by giving every 4, you're able to keep those levels nice and high and prevent that group B strep. Hopefully kill off what you have there and then prevent more from growing. As an alternative, you can do something like ampicillin. Or if they had an allergy, something like Ancef, clindamycin, vancomycin, any of those would be totally fine as an alternative. Usually penicillin is good for most patients. Now the infant themselves, once they're, they say they come into the ER or something like that, they were at home for a few days, come to the ER, and they're not really looking too well. Obviously, you got to do a full diagnostic, right? So you're getting urine cultures, you're going to be doing a lumbar puncture, you're getting a CBC, all that good stuff. But again, you got to start empiric antibiotics. But what's the important thing about getting cultures in terms of starting antibiotics? Cultures need to be before you start the antibiotics. Now, does that mean I want to delay? If I can't get the LP for, say, 2 hours, no one's able to perform it, and I got to wait 2 hours to get the antibiotics on board, do I still delay that? No, they need to get the antibiotics, right? So again, as long as there's not any kind of reasonable delay in getting those done, you want to get the cultures prior to antibiotics. And again, based off of this, you can kind of go off of sort of a, you have this ill-appearing infant, based off of their history, you can kind of decide kind of what do I need to do, right? How full of a diagnostic setup do I need to do? Do I need to start antibiotics, And so, for instance, if they're premature, say the mom did get intrapartum antibiotics, yeah, you want to go ahead, so they did not get, intrapartum antibiotics in a short enough time frame. You can see, okay, yeah, we're going to do the full court press. We're going to get antibiotics. We're going to get the LP. We're going to get all the good stuff there. Versus if they had, maybe they're a little lower risk. Maybe they had a longer gestation. Maybe the mom got enough of the intrapartum antibiotics. Then you may say, okay, well, let's just go ahead. We'll do the same labs. Maybe only going to do a 48-hour rule out. Right? So we're going to do 48 hours worth of antibiotics. If they're clinically appearing better, I don't culture anything out, then I'm going to go ahead and DC as antibiotics. Now again, we talked about things like vancomycin and gentamicin. We talked about getting therapeutic drug levels. If they're just getting 48 hours worth of therapy, do you think I need to do a therapeutic drug level? I need to be actually monitoring levels? Not typically, right? In those cases, they're going to be on for such a short period of time. They'll say, well, we're just not going to get levels. If they're going to continue on it, then we start to think about getting levels, make sure they get therapeutic, right? And then, of course, if they have a longer gestation, mom got the antibiotics for a long enough period of time, may not need any further evaluation, no for labs or anything, but you just may monitor them for, say, 48 hours. Okay, moving on to neonatal herpes. Of course, it can be caused by HS1 or HS2, depending on the case there. Usually HS2 is more common, and typically it's going to be transferred over to the kid during contact with the genital tract there. Again, you guys know what to look for, but oftentimes with these kids, especially if it's not caught early, you can develop CNS effects like seizures and whatnot can be sometimes a presenting symptom. Now, depending on kind of how the disease is going to be, how the local or disseminated is going to be, can determine sort of what kind of treatment you're going to be administering for these patients here. In some cases, you may find actual prophylactic treatment if we know mom's a known carrier in some cases. But looking at things as far as treatment goes, obviously if you have the first sign of neonatal disease, because we know they're not going to have a good immune system to fight this off, we're going to go ahead and start treatment there. And the main thing we're going to be using is going to be acyclovir, right? Acyclovir is going to be your go-to for HSV infections, and typically what we're going to do is you start them off, and again, you don't have to know the dosing specifically. I'm just trying to give you some examples of what this will look like, and depending on how disseminated it is or how local it is, you're going to find that the treatment duration may vary. So for instance, they have CNS infection, you're going to need to treat for longer. So say 3 weeks versus just 2 weeks in these cases here. Now, anyone remember some of the things you have to worry about with acyclovir as far as like kidney function goes? Got to keep the patient hydrated is one of the big things. So you can actually develop what we call crystalluria, where the drug will precipitate out in the renal tubules and cause interstitial damage. So you got to make sure they're staying well hydrated, either they're on maintenance fluids or maybe getting some additional fluids and they're receiving this. Got to keep them hydrated. Because depending on how sick they are, they could be dehydrated coming in. So you got to make sure they're nice and tanked up. Otherwise, you can see some issues from that standpoint. Next, we have respiratory distress syndrome, or RDS. Typically, you see this a lot more in premature kids who maybe not had enough time to develop their own surfactant, right? And what does surfactant help us to do in the lungs? Keeps everything nice and inflated, right? So otherwise, if you don't have any surfactant, the lungs do what? It's like a balloon you let all the air out of, right? So it kind of collapses in on itself. So the surfactant is very, very important from that standpoint. And so because of that, it's very, very important to treat this. And a lot of times we have we have a transport team that will go out and pick up these kids from outlying hospitals. One of the big things they will always carry with them, especially if it's a known premature infant, is we're going to have the surfactant with us. And we're basically, by giving them exogenous surfactant, we kind of replace what they should be producing on their own, but they aren't, and try to help kind of maintain their respiratory ability. And so, normally surfactant production starts about 32 weeks gestational age, and so obviously they come out before that, they're not really going to be producing a whole lot there. But some things we can do to help kind of predispose them to making more surfactants. One is actually give them steroids to the mom. You actually have antenatal steroids, either betamethasone or dexamethasone. That'll help to stimulate production in the baby, which is good. And some other things that can actually somehow help with this includes like prolonged rupture of the membranes actually helps to increase surfactant production, maternal hypertension, etc. But this is actually one drug we can give potentially is in order to stimulate that in the fetus. But other things you're going to find that can maybe predispose them to having RDS and decrease surfactant production there, especially if it's like a multiple pregnancy, like twins is a big one, hypoxia, rapid labor, all these different things can predispose them to that. But I want to focus on the actual treatment here. And so oftentimes we consider up to 30 weeks, we're going to go ahead and just give them prophylactic surfactant, right? And so how do you think we have to give surfactant? Because normally it's in the lungs, so how would we administer it? We got to put it into the lungs. How do we do that? Actually, we're going to do the endotracheal tube, right? So again, when you intubate a patient, the endotracheal tube, we can actually administer the surfactant directly in there, and I'll talk about how we actually administer this because it's kind of important from a administration standpoint. But basically, by doing this, by giving them prophylactic surfactant, it's going to be able to help them to maintain good respiratory function. It will help to prevent any kind of severe hypoxemia or anything that can be happening due to having a lack of that. And so there's a couple of different forms that are out there. And you also know that just be kind of familiar when you see something like Baractin or Poractin. These are the generic forms of the surfactant that we have. So we have different products there. But you notice here that we're going to give the doses mLs per kilogram, and then it's via ET tube. So obviously these patients have to be intubated for this to occur. And so basically we'll instill the volume down into the endotracheal tube, and you actually have to make sure you're rotating the patient to get basically covering each lobe of the lung, right? So actually we'll give a small amount, kind of in one position, you kind of rotate them around, and then kind of like martini glass, kind of shake them up a little. You don't do that. But it's important you have to kind of rotate the infant around to make sure they're getting nice coverage there, because you want to make sure all lobes of the lung are going to actually be penetrated with that surfactant, and they're all going to be, you kind of get the most bang for your buck. Because again, these are protein-based products, so they're pretty expensive, so when you use them, you want to make sure you get good activity out of it. Usually give several doses, usually during the first 48 hours or so. After that point, the baby hopefully is going to start to be producing their own, and then we'll kind of catch up from that standpoint. As I mentioned, usually we're going to divide it into 2 to 4 aliquots. Anyone know what aliquot is? It's like a small portion. It's going to be the name of my third child whenever she's... Okay, that would be very mean. I would never do that. But, so basically it's a small portion. So if my total volume is, say, 5 mL, so I took 1 mL portion of that, that would be an aliquot, 1 mL aliquot of that. But basically by dividing it up, and again, you're going to give it usually about a minute or so apart. You'll position the infant in different spots, so that way the surfactant will then preferentially go into different sections of the lung there. And of course, you're going to actually find that this is important. Again, most of your respiratory therapists are going to be managing this, but different brands will actually have specific ventilator settings to make sure that the ventilator function is going to be appropriate for that product being actually in there. And other thing to consider, don't filter or shake this, because again, it's a protein. What happens when you shake it up? It gets foamy. What happens to that foam? It's basically denatured proteins, no good, right? That foam, that protein needs to be in the solution for it to actually work. So never, if you have a protein-based product, don't shake it up. Don't do anything like that. You have to consider things like that. So for instance, we have a tube system in the hospital. So like when you go to the bank or something, they have the tube system that goes back and forth. We have that for the whole hospital. But one of the things you have to know is you cannot put protein-based products in the tube system because it undergoes a lot of jostling and shaking and all that stuff. And so by the time it comes out the other end, basically have a nice little protein foam shake that's going to be basically worthless at that point, right? So you have little things to think about in hospital function. Anyway, so I think that's about all the time I have for right now. I'm going to cut it off now. Let me check the board to see if anyone has any questions.